I'm Mike Wells. I primarily investigate COPD and pulmonary vascular disease, primarily associated with COPD. And most of my work spans the breadth of basic translational and some clinical research. And and really trying to think about putting together the talk, wanted to talk about updates in therapies for COPD. And other than the FLAME trial, which came out, which looked at Lama-LABA combination therapy for reduction of COPD exacerbations, there really, I think one of the biggest landmarks has been the use of supplemental oxygen in patients with COPD that have moderate hypoxemia. And so I guess you're going to have, for the purposes of this talk, you'll have to sort of change gears. Moderate hypoxemia, from what I'm talking about, is vastly different than what Dr. Willie was just talking about. So we're nowhere near ECMO for these patients. So just my disclosures, I have grant funding from the NIH and CF Foundation, and then some clinical trial funding and some consultancies. But none of these are relevant to anything I'm going to talk about today, and I won't be talking about any off-label use of anything. So thinking about oxygen and COPD, so this is something that everyone in the room is aware. COPD is a highly prevalent disease. It affects about 24 million Americans. It's a third leading cause of death in the United States, and the original studies that came out were published, were done in the 70s, but published in 1980 and 1981, looking at the use of oxygen in hypoxemic patients with COPD. Since that time, this and smoking cessation have been the only two therapies that have improved mortality in COPD. And so this is an area that is extremely important, and it addresses a major public health burden. And so I think it's really interesting to go back and sort of start from the beginning and see that in these two trials, so the first one that was done compared continuous oxygen to just continuous oxygen to nocturnal oxygen in patients that had a resting sat of less than 88%, and they followed them for about 2 years and saw that there was a mortality improvement in patients that use continuous oxygen. And this was followed up by a different study in 87 patients that randomized patients to either continuous oxygen or placebo. And in these patients, they could either have severe hypoxemia, defined as a SAT of less than 88%, or a PaO2 of less than 55, less than or equal to 55. Or they could have a slightly higher PaO2 range, but the presence of cor pulmonale or pulmonary hypertension. And this one showed that oxygen was superior to placebo. And so the takeaway from this is we know oxygen works in patients with severe hypoxemia. So what is this? What has this resulted in? Well, payers, Medicare, private insurers have adopted a pretty strict criteria for qualification for supplemental oxygen. And so these are all based on the original 290 patients that were studied. And so, as I mentioned, so this was sort of the primary indication, so just resting hypoxemia or sort of a more moderate hypoxemia with evidence of right heart failure. And this, you can also qualify patients based on exercise-induced desaturation to either one of these levels in the group 1 or group 2. And so what has become of this? Well, use of supplemental oxygen there's an increasing prevalence. So over the last decade or so, nearly 5% of all Medicare recipients are on some sort of supplemental oxygen therapy, and this accounts for about $2.15 billion a year in direct healthcare costs. And this is exclusive to Medicare. There have been some studies that have suggested that the total cost for care related to oxygen is on the order of $4.5 billion a year. So it's an extremely expensive therapy. But in the correct patient population, it does provide mortality benefit. Really trying to think about what other advantages or what other populations in COPD could supplemental oxygen benefit. In the 90s, there were a couple of different trials that looked at targeting a more moderate hypoxemia range. So with a PaO2 of 56 to 59, roughly in two different trials, either using nocturnal oxygen alone or continuous oxygen, and they found no mortality benefit. And these again were some relatively small studies that were in around 200 patients total. So we're now up to a total of just north of 400 patients that a lot of our really expensive therapy decisions have been based off of. These studies were only primarily targeted towards mortality and sort of development of pulmonary vascular disease and pulmonary hypertension, but they weren't really designed to adequately address the things that we face, and that's, do they affect other important outcomes? Do they alter risk for COPD exacerbations? Do they change quality of life? Do they improve exercise tolerance or 6-minute walk distance, or other things that are extremely important to patients? And so a trial that was done, Dr. Bill Bailey and Alan Cooper here were very instrumental and were the primary investigators looked at specifically addressing these questions. So this is the largest trial to date and is really a landmark study, and it's something that will probably never be done again in just with the amount of effort that was put into doing this study. And so the gist of what they looked at were identifying patients that either had moderate resting hypoxemia, so those that had a pulse ox between 89 and 93%, or those that during a 6-minute walk test in clinic would have some exercise-induced desaturation during the walk test. And so that was the target population, and this was randomized supplemental oxygen to placebo in a 1-to-1 fashion. And the intervention was fairly standardized across the study, where all patients were placed on at least 2 liters of oxygen, but could go higher to make sure that they maintain an oxygen saturation of 90% or greater. And it was stratified based on how the patients qualified for the different arm of the study. So if they were a resting hypoxemic patient, then they were randomized to continuous 24-hour-a-day oxygen. But if they were someone who had exercise-induced desaturation, then they were randomized to oxygen just with exercise and at night. And for the purposes of the study, they were followed annually and had phone calls and had questionnaires followed periodically. And the primary outcome, again, because of the importance of mortality and other event-driven outcomes, looked at a composite endpoint of death or first hospitalization, and then looked at a lot of key secondary endpoints, including a lot of different outcomes related to COPD exacerbation, risk, time to, etc. Looked at progression to more severe hypoxemia that would require initiation of, qualification for oxygen based on a SAT of 88% or less. Looked at changes in 6-minute walk distance, changes in quality of life, a lot of other things that are extremely important. This is the randomization or the study flow, and so what you see is that of the 1,000 or so patients that were screened, the majority of the patients were excluded because they didn't fit this qualification based on the target oxygen saturation range. And then, but ultimately, 300 patients or 370 patients were randomized to no oxygen, and 386 were randomized to supplemental oxygen. And here you see that the groups were extremely well matched. They were both groups had similar age, nearly 70 years old, majority male, majority white. There were low percent smokers in both, about 25% in each arm, and of note, all patients that were current smokers had to sign an agreement not to smoke while they used oxygen. But also the groups were very well matched in terms of quality of life as measured by the St. George Respiratory Questionnaire, lung function, and 6-minute walk distance. I mentioned before that there were several different ways that patients could qualify for this study, and between the two study arms, the reason for qualification or reason for enrollment was very similar between the groups, with the majority either being exercise induced or a combination of exercise and rest. And oxygen saturation levels measured at screening were nearly the same in both groups. So they did a good job randomizing. Now, getting to, I guess, the results of the study. Unfortunately, they did not find any difference in death or hospitalization. And this was of the composite endpoint. Of the patients that were followed for about 72 months. If they broke down the different components of the composite endpoint, so either time to death or time to death, and then first hospitalization, again there was no difference seen. Similarly, they looked at all of these secondary endpoints, and there was no difference in time to first COPD exacerbation, no difference in risk of COPD exacerbation, no changes in quality of life as measured by multiple different questionnaires, no changes in the amount of depression or anxiety the patients experience, no changes in sleep quality, no changes in lung function decline, no changes in 6-minute walk distance, and no change in room air oxygenation. So ultimately the results of this study suggest that in patients with COPD who have stable COPD that have moderate hypoxemia either at rest or during exercise, use of supplemental oxygen doesn't provide any benefit for any of these outcomes that were looked at. So where does this leave us? This is an extremely expensive therapy. The number of patients that I see in clinic that sort of fall into this sort of borderline area, it's highly prevalent. So I think that as a provider, I think to remain vigilant in monitoring all of these patients for the development of resting hypoxemia. And so how do you do that other than just sort of routine care? Well, I think this was something that we tried to address, and we published last year that in the COPD gene study, which was a cohort of about 10,000 patients that have been followed now for about 8 years. We looked at patients that had moderate to severe COPD, so gold 2 to 4 COPD, who did not have resting hypoxemia at baseline, and then we looked to see who progressed to severe hypoxemia, defined as a SAT of less than 80%. Over this 5-year period of time, and ultimately what we found is that the rate of progression was extremely low. So incident hypoxemia only occurred in 7% of the group, and then the factors when we looked at in some adjusted models, the things that I guess not surprisingly, but things that were associated with incident hypoxemia were high altitude. So of the patients that were enrolled in Denver, this really drove a lot of the signal. We did some sensitivity analyses where we excluded those patients and found that all of the other factors were still associated. So baseline oxygen saturation, so the closer you were to being hypoxemia to begin with, the more likely you were. Comorbid CHF, pulmonary artery enlargement seen on CT scan, which we've shown is a non-invasive sort of surrogate marker for pulmonary hypertension, and then patients that had had a severe COPD exacerbation in the previous year, which was defined as those who had been hospitalized. So a lot of this actually harkens back to some of the original work that was done. So really, comorbid sort of, heart-lung interaction, patients that have, comorbid either core pulmonality or heart failure are really the ones to remain that are most likely to progress to more hypoxemia. And so those are the ones to really be the most vigilant with in the screening. So some of the Other things that we can do as providers would be, absolutely continue to prescribe oxygen for those that have severe resting hypoxemia. And then it's a little less clear, but I think that in select individuals that have sort of more moderate hypoxemia, if there's somebody with intractable breathlessness or another sort of compelling reason, I think it's reasonable to give a trial of supplemental oxygen. Likewise, there are some areas that really haven't been investigated, looking at using supplemental oxygen for patients that are enrolled in pulmonary rehab and other situations. And I think when you're having these sort of discussions with patients, I think one thing to keep in mind is there was no harm shown in this study, although there was not really any tangible benefit to any of the outcomes that were looked at. And this has actually already been adopted in the most recent Gold Executive Summary that was published a couple of months ago in the Blue Journal, where the recommendation by the Gold Committee is to not use oxygen in these patients. So I think this is something that's very pertinent, and it's something that will really alter the landscape of how we tend to treat these patients in the future. And I think some of the things just that I think we really need to keep in mind are that still not completely giving up on oxygen in these patients, and that really it may provide some benefit for the really breathless patient or some other situation like that. As far as payers, Medicare has already sort of voiced full support for not withdrawing oxygen from any of the patients that have qualified based on the 6-minute walk test and based on moderate hypoxemia. There are potential changes coming to the VA system and other things, but I think and then private insurers, we're starting to get some sort of increased sort of feedback from them right now, but it's still really too early after the results of this study. So I do think that the landscape will change in the next few years. So with that, I would like to thank Victor for giving me the opportunity to speak, and just know that we are very interested in any kind of clinical trial enrollment. If you have a patient that has COPD, whether it's mild or severe, that we have a lot of different studies going on right now, looking at other things, because as I mentioned in the beginning, we don't really have any therapies for COPD that alter the natural history of the disease, and certainly other than oxygen in this very select group of patients, there's nothing that has improved mortality in the bulk of the patients that we see. So